Hi everyone, welcome to ABC's Anesthesia. I've got with me Vida again. So we're going through a massive series of the final, 2024 second sitting exam paper. And this time I've constructed the second Viva from the examinations report. So I've just made the Viva as I see it from the notes that they've given, which are extremely great comprehensive notes. And Vida's going to examine me. So hopefully I don't do too badly. Hopefully I get, give some reasonable answers. And I've Vivaed plenty of people on the spot. And I've probably got more preparation, so I should hopefully do a reasonable job. But I've asked Vida to don't hold back. Just, if I have said something odd, to definitely be like a real life examiner and probe me on this, and give me and therefore everyone some honest feedback about how I went and how I can improve. So yeah, hey Vida, how's it going?
Hi. Okay, let's get started. This is Viva 2 from 2024.2, and this setting is a very complicated scenario that will take you 2 minutes to read. So walk into the examination with your pen and a paper ready. It's 11 p.m. and you are on call at your major metropolitan hospital. The first-year anaesthetic registrar telephones you at home and asks you to attend for a case that's been booked with a surgical urgency of 1 hour. The patient is a 55-year-old woman who's been booked for a T7 to L3 debridement and laminectomy for a spontaneous epidural abscess. The observations are as follows. Heart rate 130 to 140 in AF. The blood pressure is 110 on 60 on a noradrenaline infusion running at 0.25 micrograms per kilogram per minute. The saturation is 90% on high-flow nasal oxygen at 40 litres per minute. Respiratory rate's 25. The temp is 38.5. The GCS is 11. The weight of the patient's 130 kilos, height of 155, giving her a BMI of 57. The past medical history is of Guillain-Barré syndrome 20 years previously, with an ICU admission and mechanical ventilation via tracheostomy that has since been closed. The patient is a current smoker with a 40-pack year history, type 2 diabetes mellitus on insulin, and hypertension. This first-year registrar is concerned that the patient may require urgent intubation due to falling level of consciousness, and you're 20 minutes away from the hospital. How would you approach the management of this situation?
Beautiful. So I'll probably, this is definitely one of the trickiest ends because of the length and the complexity and like the urgency. I think would make me feel kind of pressured in this situation. So I'll just tell people what I do when I look at this. First of all, I read the question. How would you approach? And as soon as it's approach, I think broad summary. So in this, I think the 5 Ps works well. So patient and pathology is the clinical stuff, and logistics is personnel, procedure, and place. So that's how I'd frame it. Now, I don't really double write anything, but what I'm going to do is I know that the stem's in front of me, so I don't have to memorize or write down a lot. I just need to make sure that I fill in, some kind of summary of how bad this is and what my approach is to the things that I suspect might be happening here. For example, it's a first-year registrar. It's after hours with not much help. They're worried that they need to intubate a patient who's going to be a really difficult intubation with falling level of consciousness, and I'm away from the hospital. So I'm going to add to that picture with my, I guess, advice or my approach. So might as well get started. So the first thing I'd say is, look, this is an extremely urgent situation and very high risk for this patient. So I'd attend immediately. I'm 20 minutes away. So I'll drive in. I'll probably be on the phone to help guide my first year registrar, who will absolutely need assistance managing this. Firstly, I'll go through the logistics before the clinical picture. And logistics are this patient, it's high risk, very sick, we'll need expert hands. So do we have other, emergency consultants or other physicians, ICU specialists to help manage the initial problem and post-op? And do we have theatre availability? Do we have the right surgeon for this? And do we have other support, for example, neurology or neurosurgeon, as well as infectious diseases? So those all might be at play here. So attend. My summary of this is that this is a very sick patient, with, with a life-threatening condition. They are hemodynamically unstable, and they've got potential airway difficulty due to the fact that they've got a high BMI. They've had a previous tracheostomy, so there might be some level of stenosis in this patient, and they've got problem oxygenating. So, they've got a significant smoking history, presumably COPD from that, and they're needing a lot of oxygen and only saturating 90%. So something's not great there, and they look septic from that cardiovascular point of view, and they're in rapid AF. So a lot of things that make this patient sick. So my approach then, while I'm coming in, is to try to help optimize as best as possible. And so this is where, I'm looking at the airway. Can we get non-invasive ventilation? Is any bronchospasm or infective cause in the lungs to treat? So starting salbutamol or Atrovent, getting advice on that, and positioning the patient from a cardiovascular point of view. With the septic picture, I'm thinking of the Surviving Sepsis campaign, ensure that I've given fluid 30 mils per kilo and titrate that, as well as, vasopressor, which you can see is running, broad spectrum antibiotics, thinking about source control and blood cultures to narrow the dosing. I'm thinking about the rapid AF. Do we need to consider DC reversion? Maybe not right now, but something to think about as I come in, but difficult with sepsis. And then just the assessment of their disease. So, what is their PACU history, COPD, exacerbations, oxygen puffers, treatments, as well as their type 2 diabetes. What's their what's their control, HbA1c, BSLs, micro and macrovascular complications. So that's probably where I'd go from there. And maybe something that the examiners might push me on is, the conscious state is falling. Do you want to intubate? And I'd say, look, this is, as long as the patient's ventilating, you're able to support that. Even the falling GCS with such a high-risk patient, I wouldn't want a first-year registrar to go ahead with that. If they have a respiratory arrest or arrest, fine, they'll manage it as they need to. But I would absolutely attend even with falling GCS for this patient, just because of the high-risk nature of an induction.
Very good. I think that was a very comprehensive answer. And this is about the recruitment of lung and the recruitment of personnel, isn't it? You're at a major hospital, so there are other personnel on board. In addition, I thought you made a very significant point of supporting the registrar, not just supporting the patient, but supporting the registrar. And these days, everybody's got a phone. Staying on the phone with the patient so that you're aware of the minute-to-minute evolution of the situation is also important. And they can call for help by asking somebody else to recruit other personnel. I thought you made a very good point. Uh-huh. I've got some...
And once we'll go through all the questions now, and then I'll share the slides and we'll go through kind of ideal answers or something. Great.
Sure. Okay, so tell me, what's a physiological difficult airway? That's a concept that we've heard of recently. And what do you do about it?
Yeah, so it's kind of the thought that even the anatomy of the airway may not be that difficult. The fact that this patient has a severe cardiovascular compromise issue will only be made worse with induction of anesthesia and positive pressure ventilation potentially. And so this is really difficult, just for that reason, if not also for the fact that they've got an anatomically challenging airway. So what that means is I'd absolutely have another pair of expert hands or a team looking after the cardiovascular side, while I'll have a team also managing the airway.
Yes, there is a lot of cognitive load here. And you mentioned it in your summary. What's concerning about this patient's hemodynamics?
Yeah, so in rapid AF, so something's happened that's triggered rapid atrial fibrillation. And what's concerning is because of their hypertension requiring a lot of NORAD, which means on induction, they could have a cardiac arrest. The thoughts I have are the sepsis has probably triggered this. I would want to check gases, check electrolytes, check pH, and check any other reversible causes, which is probably the sepsis, which we need to treat. DC reversion, this patient probably won't work, but I might get some advice on that. So the traditional plan of, DC revert anyone who's compromised may not work in this patient, may cause further decline as well. So I'd be very cautious about that.
Important not to forget neurogenic shock, especially in this situation for this patient.
Yeah, so we've got three forms of shock here: septic shock, neurogenic shock, and cardiogenic shock. So I'd be very concerned. So
Yeah, and how would you differentiate septic from neurogenic shock?
Yeah, so there's a number of ways. I mean, both present with hypotension and they're distributive forms of shock. The clear things would be the preceding cause. One would be, which exists in this patient, which is some level of potential neurotrauma from the abscess or compression, but that's also part of the septic picture. Septic patients may be febrile, like in this case, whereas neurogenic shock patients could potentially be normothermic or hypothermic. Depending on the level of lesion, septic patients are tachycardic. This patient may be normocardic or bradycardic and need management of that. Those would be probably the major ways I'd differentiate. Differentiate.
So if you mentioned that, I would ask you, what's the origin of the cardiac accelerator fibers? This lesion is
T1 to T4.
Yeah, that's right. So once you mention that, be prepared to deliver the answer. So tell me, what's the management for septic shock versus neurogenic shock?
Yeah, so there's similarities in giving volume resus and vasopressor and looking for septic shock surviving sepsis campaign guidelines. I'd need expert help, fluid load, 30 mils per kilo, if not initially over the first couple of hours, and then titrate, as well as starting a vasopressor via a central line and monitoring. I'd also want to take blood cultures and find the infective source, as well as source control, which is the operation, and start broad spectrum antibiotics. With neurogenic shock, I'm thinking of spinal precautions and trying to, again, similarly repair the issue. Corticosteroids might be an issue, might be part of the treatment. And not in this case, but if the patient was bradycardic, I'd be looking at heart rate control and giving atropine to raise the heart rate appropriately. Those would be the main things I'd be looking at.
Yeah. The cognitive load certainly is being piled on in this Viva. It just seems to be unraveling. Because, of course, cardiogenic shock in the setting of sepsis can be a concomitant of neurogenic shock in the setting of a spinal abscess. Okay, so we've mentioned this. I think you've got some slides on septic shock and neurogenic shock management. You transfer them to theatre for an urgent debridement and laminectomy. How will you induce this patient?
Yes, there's a high-risk intubation, not, as we mentioned, physiologically from the cardiovascular hemodynamics point of view, also from the airway. So first, my assessment, if I was worried about tracheal stenosis, and I'd look for signs of stridor or any kind of narrowing. Is there a previous CT? Is there a previous nasal endoscopy? I'd want to make sure that this wasn't a definitive narrowing. And I'm also very worried about the oxygenation and the hemodynamics. So for my plan, for the induction, it'd be a very cautious induction, have fluid ready, have my vasopressor turned up. So if I'm at 14, I'd probably turn up to give me a bit more room to move. It'd be a very gentle induction. With this 130 kilo patient, I'd probably give a couple of midaz, maybe only 50 of ketamine, have ephedrine and aramine ready to bolus, as well as having the NORAD up, and then give 150 of rock. I don't think we need to wake this patient up anytime soon. And intubate. I'd probably give, I don't think I really need, I really want the cardiovascular support, so I'd probably give 100 of fentanyl and not much more than that. At the same time, my airway plan needs to involve, the potential of difficult airways, so having the patient ramped, having really good oxygenation, keeping the high flow on, making sure their pre-oxygenation is absolutely on point at, end-tidal greater than 80 or 90% if possible. As well as having a lot of different things to bail me out if there is stenosis, but having a video laryngoscope for this case, having a bronch as well, and a range of different tubes. So having, I'll use this is a male, size 8 tube, but having size 7 and size 6 tube, and even an MLT, just in case there's some kind of an issue with the previous tracheostomy. I would expect a desaturation with this intubation as well, but these are the things that I'd do for the case. I'd have a CBC and outline as well.
Sure. You have described it, but it would be useful to itemize your plan A, plan B. You've actually told me about a plan A, plan B, and a plan C, but it is even a good signal to say my plan A is this. If that doesn't work, I escalate to this. And you have already asked advice from the ENT surgeons.
Yeah.
The patient does desaturate, as you anticipated, after intubation from 91% to 75%. What will you do?
Yes, this is concerning but not unexpected. First thing I do is check the placement on my tube, assuming it's at the appropriate distance. I would 100% oxygen, increase my flows, hand bag to check for compliance, look for rise and fall of the chest. And I'd probably start with just auscultating the lungs in the first instance and looking for obvious things like bronchospasm or endobronchial intubation. But then also look at the tube itself, look at the circuit to see if there's any issues there.
Excellent. The problem is solved with these efforts. You determine that the patient's just desaturated during the rapid sequence induction due to her lack of reserve. How will you put this patient in the prone position?
Yeah, so proning this patient will be a challenging exercise, especially for the fact that I've got a difficult airway, I've got inotropes running, I've got a patient very prone to desaturation, and they need some level of spinal precaution on the turn as well. So I'll need lots of personnel, I'll need a good logistical plan, and I'm thinking of all the things of ensuring that all my tube is there, safe. My lines are managed separately. I've got the patient, the lines appropriately on the side of the patient so that they rotate appropriately. I've got a bed with all the pressure areas and hopefully a pillow that has the belly loose and also the foam on the head. Now, depending on how unstable this patient is, I'll try to keep the tube connected or put the pillow on the face and reconnect and connect with the tube. And that will be not an easy thing to do. So I'll absolutely have to check for that. And I'll be making sure that the patient has all the appropriate padded areas, that there's no likely pressure sores, especially on the eyes. One of the standard things we do. And then after the period of turning, I'm observing, just checking that everything's okay, that ventilation, oxygenation, and the hemodynamics are fine. Often turning is when hemodynamic compromise can occur. And I also have a return to supine plan. In any kind of emergency, I need to have the bed right there, and the team very well aware that in this very difficult patient, I might need to turn in a hurry and what that plan is.
That's very good. In fact, I was able to visualize what you were going to do with each step of the way. My habit for turning patients is to disconnect as much as I can, but I agree that in this patient, you may not want to disconnect the airway, and signaling that you will consider, do you tie or do you tape the tube in? Again, reassures me that you are thinking about what the most secure way is to fix all of these things, because that's, of course, where, and anticipating the problem is halfway to the solution.
So I did forget to say that, because obviously I wrote in the notes I did.
Yes.
So it's funny when you're overloaded with information, it's easy to forget that, of course I...
And I think that is the exercise in this Viva. There is a lot to think of. So visualizing in your own mind and describing what you go through with the patient that of these dimensions and all of the feng shui that is required is a good aid to giving a comprehensive answer.
Yes.
So 1 minute after putting the patient prone, the airway pressure alarm sounds. The tidal volume is only 200 mils with 40 centimeters of pressure of water. Saturations fall to 85%. What will you do?
Yeah, so again, really concerning because of the awkwardness of the position. So I'd immediately call for help, get people in ready to turn if needed. But in my first instance, I would, get everyone to stop what they're doing, alert that there's a problem here, 100% oxygen, increased flows, handbag, again, checking for compliance. And then I'd do a really systematic check. Anything can happen on the turn. So I'd check the circuit, check the tube, check where it is at the mouth if I could, as well as check for any kinks or any kind of blockages, because that would be a common cause of increased pressure. I would also then auscultate the lungs. Bronchospasm could be a cause. Endobronchial intubation could be a cause. I'm thinking of any kind of mucus plugging as well. And those would be the steps I'd go through to see what's going on. Again, in this large patient, maybe 130 kilos prone, this patient might be difficult to ventilate, and I might need to just accept these higher pressures because that's just part of this patient's makeup.
Okay, so in fact, it ends up in this patient that the issue is most likely due to the weight of the patient in that prone position, as you've said. How would you manage this patient's ventilation modes now?
This is complex because the patient is obese and also have some, smoking history and probably some level of COPD. So assuming this is not an obstructive picture, but it is a restrictive lung disease problem, I would institute restricted lung mode kind of ventilation, which means I would use pressure control. I would titrate the pressure up to have a reasonable tidal volume, but where I'm getting no further benefit of pressure, I'd limit it at 30 or 40 or whatever pressure is safe. I would not go above 40 without review. I'm looking at low tidal volumes, but a higher rest rate. So I titrate 15, 20, rest rate even 25. And I would inverse ratio. So having a longer inspiratory time, the ratio, i.e. 1-to-1 would be what I do, and potentially even go 0.5-to-1 depending on how things are going. My priorities here are oxygenation. So even if the CO2 climbed to some level of 60 or 70, the problem here is, managing to get enough ventilation oxygenation. So I'd probably accept a higher CO2 in this patient, knowing that they're also COPD.
Those are very practical points. One of the other very reassuring things that you said was that you anticipated this problem. You anticipated the problem in the answers to the previous questions that I asked you. That's very reassuring. Then you go on to elaborate your plan. One of the other words that you used, and I often encourage people to just keep Post-it notes of their favorite expressions during Viva practice. And one of the things was you perform a systematic examination. Even if you omit an element, you are signaling to the examiner that you have in your mind a systematic construct, either from the patient to the machine, whatever it is. I don't mind what it is, but you are signaling to the examiner that you have a way of thinking that encompasses most of the important things in the response to a scenario. Mm. So back to the question. After completing the surgery, the patient is being ventilated as you have outlined. The noradrenaline is being delivered at 15 micrograms per minute via the central line, and the peripheral line is tissued, but with no visible veins due to obesity, and there have been no other lines placed. So you just got the central line for this patient with difficult venous access. You leave your registrar with the patient and go for a break. You hear the buzzer and rush back. You can just see this scenario evolving, can't you? The patient is supine with central access accidentally having been removed on transfer. What's your response when you hear that buzzer?
There's a crisis. So I've got a patient who is hemodynamically incredibly unstable now without inotropes, noradrenaline being infused, and that is a deadly situation, especially in a patient with difficult vascular access. So I mean, this is clearly a crisis. I'd call for extra assistance, and the important thing here is I need specialist assistance in a couple of things. So the first thing would, if there's bleeding at the source, I just have one of the nurses just put some pressure on there. The most important things here would be to somehow temporize this patient's blood pressure without vascular access, and then find some kind of vascular access. So for temporization, I'd probably myself be titrating IM adrenaline or IM ephedrine. And in the first instance, 30 milligrams of IM ephedrine may be the easiest thing to do. The dose of IM adrenaline may be tricky, but this would be comparable to like an anaphylaxis type hypertension. So I think 500 micrograms in the first instance wouldn't be too much. And then I'd continuously reassess and redose that as well. I think that's probably the best agent in intramuscular format, but intratracheal, I could probably give doses as well, 100 mics to 500 mics. From vascular access point of view, number of things. If I could have, a number of specialists with this, one for intraosseous access, that might be the quickest way of doing things, but also someone to, get the ultrasound on the internal jugular on the other side or the femoral vein and just put a long cannula in. That might be one of the easiest and most familiar ways of getting access. I'd also have someone with an ultrasound on other sites, and these might be sites that are still present and easy enough to get but rarely used, like the back of the wrist, as well as the saphenous and even the external jugular and maybe even some forehead veins. So just we're in such a desperate situation here that I would try absolutely anything, but intraosseous internal or central access with a cannula, or the lesser known veins or the lesser used veins. All I need is a 24 gauge to get
correct. Yes.
Stuff in. Yeah. So
and A and B is taken care of, and you demonstrated excellent situational awareness that you can use the trachea to deliver drugs, not particularly effectively, as we know, but that is something. The recruitment of personnel and the acknowledgement that you don't need a 14 gauge. A 24 gauge will do. That's the end of this Viva. You did very well.
Thank you. Thanks for that. Hey, you
stick with anesthesia here.
Hey, so just for everyone watching on YouTube, here are the slides just of the whole approach. So I'll just quickly flash them up. And the section one, I've just got the questions here in bold. Hopefully I went through most of these points. And as you saw, Vida had to probe on certain things, and that was totally fine and expected with anyone being, in an exam, being examined. Literally, I just chucked some of these questions into ChatGPT to get some reasonable answers, including the septic shock versus neurogenic shock, and came up with some decent answers there, which are worth having a read. So feel free to pause here.
And I think that's a very good thought experiment to do when you're reading an exam question. The 2024.2 exam questions are not going to be repeated in the next exam. So it's important to think widely, what could be the launching pad for another question on a similar topic? And I think something that I notice in candidates is that neurogenic shock as a cause for hypotension is often forgotten by candidates. So this is, I think, a very useful exercise to go to. The other learning point for me for this question is just the pile-on. There were many causes of hypotension, many disasters, and it really devolved into farce by the end. You could just imagine the scenario. And if this was a real situation that happened to somebody, it may well have had the ultimate and tragic outcome. But it is a pile-on, and it is very important to maintain an organised approach of ABC to this sort of situation, and to recognise what you actually want. You just want access. You've got control of airway and breathing and so on. Absolutely. So I thought it was a very good exercise and quite different from the other Vivas in this suite.
Yeah, absolutely. Section 1, we've got my approach of hemodynamics versus the airway plan, and you mentioned I could have done better with kind of saying there's my plan A, B, and C, depending on how things go, where I probably did a more scattered approach of these are all the things that I might need globally. Patient desaturates, have a systematic response to that, purring the patient. I forgot to mention whether I'd tape or tie, but hopefully got the other stuff. They actually mentioned in the examiner's report a discussion of a short evaluation period after purring the patient to assess the stability of ventilation hemodynamics. So I know that we all do that in real life.
Yeah.
But just I wonder how that was, like, I can imagine not mentioning that if I was asked, how do you prone the patient? But I know that I would do it. So I wonder what that discussion would look like. And hopefully people remember to mention that just because that's something that they examined on.
This was a really good scenario to put yourself in the situation, walk yourself through the room. You're in the operating theatre. What would you actually do? We have the mirrors underneath the tables for our prone tables, and I use them quite a lot. You often have to shield yourself from salivary secretions from the patient, but I think that's a very significant in-place, real situation description to include in your response.
Great. Now, so we went through this, and again, my idea is you just got to give the whole story. You've got to say everything you do. You can say it quickly. The more questions you ask, the less time, the more time it takes you to say something that's actually something that's pretty easy, something that we do all the time. Not only saying your method of sorting out and temporizing your hypoxemia, but also what's causing this. And there's lots of easy things to say and things to do quite quickly. And then. What is your restrictive mode ventilation? And this could have been obstructive. We just went down the restrictive path, but that's lesser known, I guess. So that's why I chose to examine on this.
This is also a Viva full of grey, wasn't it? It wasn't just obstructive. It was also the possibility of restrictive. It was hypotension from, you pick a cause, septic, neurogenic, hemodynamic due to a rate decompensation. I thought it was a great question to just stay simple and systematic. It was very good.
And then we've already talked about this, but this is for me, if you look at my CRM lecture, you've got the usual stuff, but I absolutely have a list of priorities, and the priorities are I need to temporize and I need to gain access. And in real life, this means you don't do things linearly. If you're just giving adrenaline and then you're doing access, this patient could have those two things happening in parallel if you have the staff to do it. So, if you only had yourself, maybe you'd tell a nurse you'd give them the adrenaline and say, hey, just 0.5 ml, whenever you see the blood pressure dropping, or, every 5 minutes or whatever you want. But you've got to assign tasks in this, otherwise it's not realistic. And without a parallel management approach, I don't think you get to a good outcome with this patient.
Yeah, you reconstructed a great Viva. I thought it was very good.
Excellent. Hey guys, so next time we're going to go through Vivas 3 and then 4. So all of this will come out on the ABCs of Anesthesia podcast and YouTube channel, and with the ASA as well. See you again next time. Thank you very much, Vida. You're a gem.
Bye-bye. Thank you. Pleasure.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.